So let's move on and talk about some combination approaches in the EGFR space. I've always believed that we should just be using targeted therapy and that, sparing our patients chemotherapy, that was a whole concept behind precision medicine. But we had some very interesting data at ASCO this year looking at the combination of chemotherapy with a TKI versus TKI alone in an EGFR mutant patient population. Suresh, you want to go over that data briefly?
Yeah, and for me, this study, the NEJ009, it's a cooperative group from Japan. Dr. Nakamura was the principal investigator. And they presented a phase 3 study comparing gefitinib monotherapy versus gefitinib plus carboplatin and pemetrexed, sort of triplet combination in patients with EGFR mutations. And I will say that this was definitely the most impressive study to me, probably because I was not expecting this sort of a result. Exactly. And so patients who had EGFR mutations, again, sensitive mutations, exon 19 deletion and L858R exon 21 mutation, were randomized to gefitinib or gefitinib plus chemotherapy. Standard doses of all three agents, so there was no dose reductions in the triplet combination. And the primary endpoint was overall survival. So this was not a study, which most studies have been designed in this space, where progression-free survival, but this study was designed with the primary endpoint of overall survival. But they also looked at two other endpoints that were interesting. They looked at what they considered as progression-free survival 1, that is, what was the time to progression from treatment initiation to first documented progression, as well as they looked at progression-free survival 2, that is, after the patient had the first progression, whatever treatment they received subsequently, and in the gefitinib arm, they had to receive carboplatin, pemetrexed. They assessed the progression-free survival 2 as well. And what the study showed, the primary as far as primary endpoint was concerned, was that there was improvement in overall survival with a hazard ratio that 0.69, which translated into a median progression-free survival of 20 months with the combination of gefitinib and chemotherapy, and a progression-free survival with gefitinib patients of only 10 months. But what was even more interesting was that the difference appeared to be, when you looked at the differences in progression-free survival 1 and progression-free survival 2, the progression-free survival 1 was where the difference was seen with the triplet combination compared to gefitinib. Whereas once the patient progressed, the second progression-free survival was equivalent in the two arms, suggesting that you need to have a much more complete therapy, if I can say that, in the beginning to produce an improvement in overall survival. And the speculation here is that by giving the triplet therapy, you're probably targeting multiple different clones that may not be as well targeted by single agent EGFR TKI, and therefore you are seeing the survival improvement. Also, when you look at the medians are what one would expect. So with single agent gefitinib, the median survival was about 38 months, 39 months, and it was about 52 months with the triplet combination. So suggesting that the improvement in survival was not because the standard arm underperformed.
Yeah, so Anne, go ahead.
So this made huge waves, right? But my argument is that this is using gefitinib.
Correct.
It is not comparing or using osimertinib, which we now largely use as our standard of care. And so while I understand that, yes, it's a positive trial, I have a hard time thinking that this can be implemented in the US.
So are you going to take the leap of faith and use osimertinib with carboplatin?
No.
And I completely agree with that. I think that at the present time, this is very interesting data, and one has to say, at least if you compare the medians, it is no different than what one would see with osimertinib alone, and I rather give a single pill than an IV chemotherapy. But it raises the prospect, one, that maybe we will see even better outcomes if you combine chemotherapy with osimertinib, but also that maybe there is value in now combination treatments, maybe a better understanding of the biology of the tumor and identifying what good partners, even maybe beyond chemotherapy, to sort of improve upon the current standard of care.
Miller, you had a comment?
I think it opens our options for more trials. I agree with Anne that at this point I don't think this changes my practice, but should there be a trial knocking on my door, randomizing patients to osimertinib versus osimertinib to chemotherapy, I think I would be very interested in bringing it in.
Yeah. I'm torn by this data. In some ways, I am overwhelmed by the survival data and seeing that type of difference, which is meaningful for patients. But and the philosophical view is, are we moving backwards by just adding chemo to everything? We've learned in 189, just add chemo. This is not the topic that we're going to be handling with immunotherapy, but just adding chemo to targeted therapy and showing that improvement. It's just, it runs against a little bit of the precision medicine paradigm, but it does speak to or highlight some of the hints that we're getting from tumor biology and the tumor heterogeneity and subclonal events that are happening up front that may be wiped out by chemotherapy, that may be not touched by the targeted therapy.
Right. But my argument again is, you know, we don't know with osimertinib.
Right.
And
Correct.
osimertinib may be
Correct.
totally fine, and then we add in chemo later when they progress, and you put those
Right.
clones down. So there's
And it would
a
be
lot
wrong to
that's
extrapolate
unknown.
at this point.
Yeah.
Exactly.
I think
We
that's the
shouldn't make any
message.
We
extrapolation
at
there.
least are sure about one clone that it suppresses T790M in addition to the EGFR sensitive populations.
So the message, I think, from all of us is osimertinib still remains the standard. Off of clinical trial, chemotherapy should not be added to this drug. It should be added in a sequential fashion.